thank you so much for the invitation to present. I was able to join you in person 5 years ago. A little disappointed I can't be there today, but hopefully you can get something out of my presentation. So today's topic is extended, or the eFAST exam, so which stands for Extended Focused Abdominal Sonography in Trauma. So eFAST is often used when we have motor vehicle accidents as depicted in this scene, but it can also be used for things like blunt trauma and ectopic pregnancy. Still in presenter view. Hang on, let me do this way. Is that better? Am I in the right view now?
Yes, this is the right view. Thank you.
Right. So we can use the eFAST exam also in blunt trauma and to evaluate hemoperitoneum. And that eFAST, the extended bit, now includes the lungs, which can cover off on lung evaluation for pneumothorax, among other things. But it's really, really important doing all that you have a good idea of what's normal. So in today's presentation, I want to take you through some of the normal and abnormal appearances, and also just the technique that we're going to use to do the FAST exam. So when you're doing a FAST exam, what can you see? You can see intraperitoneal hemorrhage, you can see pneumothorax, you can see traumatic pericardial effusions and pneumothorax. Now, if you have a patient and you don't have access to CT, you may need to repeat the eFAST exam to be able to allow time for some of those, for that fluid to develop and to be able to be seen. On the FAST exam, depending on which articles you read, the minimum amount of fluid that we can see is anywhere between 250 and 500 mils of fluid, which is quite a bit. But you may need to allow time for there to be enough bleeding so that you can see that fluid. What you can't see on the FAST exam is injuries that don't cause free fluid. So, for example, if there's a ruptured kidney and that's contained within the renal capsule and it doesn't cause free fluid in the peritoneum, then you're not going to be able to see anything on the FAST exam. Retroperitoneal free fluid can't be seen, so aortic ruptures are very difficult for us to see the fluid collecting from that. If we scan too early, you might miss accumulating fluid. And if there's solid organ injury, we can't see that on the ultrasound. What we're looking for are the effects of that solid organ injury, not the solid organ injury itself. And this was brought home to me very clearly. I was involved in the care of a patient, young girl, 20-something years old, and we scanned her FAST exam and it looked reasonably more normal. She went off to CT, showed a massively ruptured spleen and a fractured pelvis. And then when she came back, we did another FAST exam. And now that we knew that going on, perhaps you could see that there's a little bit of free fluid, but the ruptured spleen looked completely normal, and yet on CT it was a real mess. So I know I've said that many times, but to actually see that you don't see that solid injury very well in the flesh, so to speak, was really quite shocking that we'd missed it, I felt, but that's normal in a FAST exam. Now, the other indications are ectopic pregnancy and in a ruptured appendix. Now, when we're doing the FAST exam, the perfect FAST exam, it would be ideal if we used every single one of these probes. So for the abdominal part of the scan, we'd use the curved probe on the left here because that gives us the best images. For the lung part of the scan, we'd use the linear probe because we get good detail about the pleural line because it's close to the surface. And for the cardiac part of the exam, we would use the phased array probe because it fits nicely into the windows, and that would allow us the flexibility to go and do some parasternal views as well if we needed to. But a FAST exam, part of that is that you need to do this in a hurry. So we're trying to get an evaluation of the patient in less than 5 minutes to determine if there's any life-threatening injuries causing free fluid that needs this patient to go to theatre. So we don't have time to faff around changing probes. And so my go-to, which kind of is the best pick out of the bunch, is to use the curved probe here. because it gives me great detail about the abdomen. I can get by to get the subcostal views of the heart. And if I change my depth, I'm going to get reasonable views of the pleural line. So the 6 views that we are going to do is the right upper quadrant, left upper quadrant, the pelvic exam, the subcostal view of the heart, and then we're going to also have a look at the anterior chest wall, looking for pneumothorax. And we're going to use a paint the fence kind of technique. I don't want you to just plonk your probe down and expect that the pathology is going to be under your probe. You actually need to paint the fence and scan through the area so that you get a view of the region. You're looking at the right upper quadrant, not just the mid-axillary line. So whilst that's our starting point, we're then going to paint the fence and do brushstroke motions to get a view of the right or the left, wherever we are, to get a view of that region rather than just one spot. We're going to use 3 depth settings throughout the exam, 6 centimetres, 16 and 26 centimetres. So the 6 centimetre setting is for the chest, and if you put your depth at 6 centimetres, the pleural line will now be in the focal zone of your computer, of your ultrasound machine. We'll use a 16 centimetre depth for your average body habitus patient for their abdomen. And again, for the average body habitus patient, we'll use a depth of 26 centimetres for that subcostal view of the heart. If your patient is much larger than average in size, you're going to have to increase these depth settings. If they're much thinner, or if you're scanning a child, you'd need to adjust your depth settings down. But it's easy to remember, 6, 16 and 26. So let's start with the right upper quadrant. We are going to start by locating the xiphisternum. Oops. Come back. We're going to start by locating the xiphisternum, and we put our probe on at about the mid-axillary line here. Now, as the patient is lying down, you can see that the head end of the patient is on the left-hand side of the ultrasound image here, and the feet end is on the right-hand side of the image. And when we correlate it with this CT image here, you can see the diaphragm, which is this bright white linear line, the even texture of the liver, and then we can see just the top of the kidney here. And what that's going to do is let me look in the 5 really crucial areas that we will see the fluid. And so those 5 areas, now this is the same for both right and left upper quadrant. We need to look above the diaphragm in the pleural cavity, looking for signs of hemothorax. We need to, and it will present above the diaphragm on the ultrasound. We need to look between the diaphragm and the top or the dome of the liver. We need to look in Morrison's pouch between the liver and the right kidney. And then we also need to look and see around the tip of the liver here and the inferior pole of the kidney there to see if there's any free fluid in the flank. And if I see free fluid at the bottom of the kidney, there's a lot of free fluid. Now, when we put the probe on, as I said, we're going to start at about the mid-axillary line. So we're just going to hold the probe and rest it in our hand so that we can do those brush strokes and examine the region. So we start at about the mid-axillary line here at the level of the xiphisternum. Then we're going to paint the fence, and then we will move upper rib space, do up and down, paint the fence, and then move a rib space lower than the lower costal margin. So the xiphisternum's here, mid-axillary line. As we move our probe, we're going to be able to examine the Morrison's pouch through here, and that's at about the level of the xiphisternum. If we come up a rib space, we'll catch the pleural cavity and the subdiaphragmatic area. And if we come a rib space down from our starting point, we'll catch the liver tip and the lower pole of the right kidney. So here's an example as we're scanning through. It's a very quick scan through here, showing that you need to move through those different rib spaces, and that it's not always the perfect image, but you're looking for fluid. So sometimes the anatomy will go behind the rib. So you can see here we have free fluid here sitting in Morrison's pouch. This black line here delineates the free fluid. And we have some fluid here around the lower pole. And you can see how it conforms to the shape of the organs. So these two round bits here are the bowel, and the fluid will wrap around them and form nice smooth lines where it's against the organs, and it fills in all the nooks and crannies. And so it forms sharp angles, as you can see up here. Now, as we come up a rib space, you can see here's the liver, and we have the linear bright white line of the diaphragm, and here we can see quite a bit of free fluid in the pleural cavity. And so what we look for is the spine sign. You can see the spine here. Now this one has free fluid in between the liver and the kidney, so in Morrison's pouch, around the tip, and you can see it coming into the subdiaphragmatic area. And they say that about a 0.5 centimetre measurement here is roughly equivalent to 500 mils, 1 centimetre, and it's just a visual thing. 1 centimetre is about a litre, 2 centimetres is about 2 litres. But you notice here we can see the spine coming along here, and then it kind of stops just up here, and then we can't see it above the diaphragm. And I have a better picture of that here. On the left we have normal. You can see the lung sliding into view here, and the air in the lung stops the sound from traveling through, and so we don't see the spine above the diaphragm in the normal patient. So you can see the spine coming along here, and at the diaphragm we see a little bit more spine as this patient's breathing, and then it comes back again. And that's because the air gets in the way and the sound's bouncing off the air, and so there's no sound transmission through to the spine. We have the gallbladder here, blind ending tube. We can see a bit of free fluid here around the liver. And so the thing here is, if you're concerned that it's a gallbladder instead of free fluid, if you turn your probe into the short axis view, the gallbladder will change shape and it will look quite different. You could mistake a renal cyst for free fluid, but again, this fluid, yes, it's black, but it's contained, and so you can see the circular structure here of the cyst, and it pushes things away. Free fluid conforms around the organs and fits into all the nooks and crannies. IVC can be mistaken for free fluid, and so the thing here is to watch as the patient is breathing. We should see respiratory variation and collapsibility of the IVC. Perinephric fat, so you can see just a little rim here. This one's easy to mistake, but you can see that there's a little bit of stranding here. And again, if we go into a different view, go to the transverse view, or even if your patient is able to change their position, if they change their position, the fluid should be gravity dependent, and so it should sort of go to the bottom wherever the patient's position is. And lastly, we can't determine the difference between someone who has free fluid because they've had a traumatic incident and free fluid caused by bleeding versus ascites. So it is possible that someone with end-stage liver disease or ascites also has an accident, and you won't be able to tell the difference. So that's a frustrating limitation of the FAST exam. Now, if we look at the left upper quadrant, things are very similar on the left side. We're looking in those same spaces. So the way we're looking at the patient here, the way it's presented on our image is that we have the patient's head end on the left-hand side of the screen, feet on the right. We can see the diaphragm. The spleen is a crescent-shaped organ. It looks very, very similar to the liver. The shape is what gives it away, and it should be in the normal patient. It's usually quite a bit smaller. There's quite a big variety of normal spleen size in your normal patient. Some people have just a tiny sliver of tissue, and other people have splenomegaly associated with other disease processes. But you're looking for that crescent moon shape, and you can just see the top of the left kidney here. So we're looking in those same places that we did in the right upper quadrant, in the pleural cavity, between the diaphragm and the spleen, in the splenorenal angle here between the spleen and the kidney, around the tip of the spleen and around the lower hole of the left kidney. And so we use the same technique, except this time we want to start a little bit further back. So we're going to go for the posterior axillary line this time. And another easy way to think about that is when you are holding the probe, I want you to put the back of your hand on the bed. That means that you are getting posterior enough. Remember that the stomach sits anteriorly there, and we don't get very good views through the stomach. The other thing I'm going to get you to do here, so the probe marker would point to the patient's armpit, and if the patient was in a clock, that's probably, if the armpit is 12 o'clock, you're just going to rotate the top of the probe ever so slightly around to that 1 o'clock position. And what that allows you to do is to just get in between the ribs a little better to get a better view of the spleen. And so you can see here that the probe is ever so slightly angled with the probe marker pointing backwards a little bit. We're starting with the back of our hand on the bed. And so we look at those same 5 spots. So if we put our probe on at the mid-axillary line, we're in line with the spleen and the splenorenal space. And so we're going to rotate the probe slightly and then paint the fence. And then we need to move upper rib space so that we catch the area under the diaphragm and the pleural cavity. And from our starting point, we move down a rib space to see if we can see anything around the lower pole of the kidney and in the paracolic gutters. So if you just rotate your probe ever so slightly here to that 1 o'clock position, I've got a video clip here of the effect of that. Here we rotate a little bit, you can see lovely crescent shaped spleen, and then it kind of disappears when we go straight on the patient again. We rotate here, it's rotated a little bit, and then if we come back to the straight position, we lose visibility of the spleen. So that's my top tip for the left upper quadrant. And again, paint the fence, we're going to come through and look through at least 3 rib spaces because we're scanning the left quadrant, not just the splenorenal space. You can see in this example, the patient breathing, so the lung is sliding over the top here. You can see the diaphragm. We can't see any spine above the diaphragm, so I can see and rule out fluid in the pleural cavity. I can't see any fluid here underneath the diaphragm or even between the splenorenal space here. Whereas when we do have fluid, now it can be tricky in this right upper quadrant. We've got a bit of an issue here with contact. It's probably resting on the patient's clothes, so you've got to get them out of the road. But you can see a little bit of free fluid just around the tip of the spleen here. And here we've got a tiny sliver of fluid in the splenorenal space, quite a bit more fluid here on the left, underneath the diaphragm and around the tip, and even here in the splenorenal space. And here, here we can see free fluid in the pleural cavity. And here's some cranky looking lung. Now the false positives in the left upper quadrant, if you position your probe too anteriorly, then you might come across fluid in the stomach. And fluid anywhere looks black with fluid. You can see a bit of whatever they'd have to eat here is all just floaties there, but it's quite well contained, and it's a physical structure here where the you can see the stomach is containing that fluid. The other one is a cyst, like we had on the right. So the cyst will push things away. Free fluid will conform around the organs, whereas this is quite nicely a cyst. And the criteria for the cyst, it's round, it's black, and we have good through transmission, whereas free fluid sort of fits into all those nooks and crannies and is not round. Now the next step is pelvis, and the top tip here, you're going to start with by identifying where in the female, the uterus and the vagina is, because these kind of make like an arrow here that points to the deep area where the pouch of Douglas is. And so what we're going to do is we're going to put our probe on the patient in the longitudinal orientation, probe marker to the head. We're putting it on their tummy. We're going to drag the probe down until it bumps against the symphysis pubis, and then directly towards the floor, or even to angle up slightly so that we can see we've got bladder, then the short bit of the cervix and the vagina makes like a Nike tick, or you've got like the uterus and the vagina making an arrow, and the free fluid sits posteriorly. So here we have bladder, uterus, vagina, and we need to look here for the free fluid. So in the ladies, we should see the free fluid sitting deep to the uterus. And the more the fluid extends up the posterior wall of the uterus here, the more free fluid there is. Here is an example of ascites. And so you can see in this extreme case of fluid that it really fills up the pouch of Douglas. You can see the fluid conforming around the bowel loops here and even falling into the anterior cul-de-sac here. In the men, we have bladder. We can see prostate here. And again, the bladder kind of makes like an arrow, which guides me to look at that deeper area and points to where the fluid accumulates in the retrovesicular pouch. And so you can see for the guys, bladder like an arrow. Here's our prostate. The free fluid sits around the back here. One of the tricky things about the pelvis is that you need to have your gain set a little darker than elsewhere, because what happens as the sound goes through the bladder, there's nothing stopping it, and so you often get posterior acoustic enhancement behind the bladder, and what that can do is bleach out and write echoes into the pouch of Douglas or the retrovesicular pouch, so you miss the fluid. So the first thing to do is to get your gain set right so that your bladder's black, and wind down the far field gain so that you don't miss fluid in the pouch of Douglas or the retrovesicular pouch. Here we can see some clotted blood in this pouch, the retrovesicular pouch. We have the prostate up here, and here we've got some free fluid sort of coming more superiorly. In the ladies, we've got it sitting behind the uterus. In the guys, prostate is here, and it's going to be north of the angle of the bladder there. So that scan technique again, probe marker to the patient's head, drag it down until you bump the bottom of the probe against the symphysis pubis, and then you're going to rock your probe down so that it points straight to the floor, and directly under your probe will be the area that we're looking for, pouch of Douglas or the retrovesicular pouch. Now, it is important that you do use a thorough scan technique, so you are scanning the pelvis, not just the midline. If you happen to have a patient who has endometriosis, the scarring from endometriosis and the endometrial deposits are likely to hang out in the pouch of Douglas as well. And so it can scar it up, and that will mean that you have an unusual sort of pattern for where free fluid would collect. So it's important that you scan the pelvis all the way from the iliac vessels to the opposite side iliac vessels. And if you're having trouble, then we're going to turn into transverse and make sure we go down to symphysis pubis all the way up to the umbilicus. You can see here as we scan through the pelvis, not just putting a still image in the midline. Here we have a more moderately full bladder. We're going all the way. Here's an ovary. Here's the uterus and vagina over to the other ovary. Guys, so we've got symphysis pubis here, the bladder, prostate is in here, in the midline there. We're looking around here. When we go in transverse, you start at the symphysis pubis, and as you start to fan towards the head, you'll see the bladder. Now, the false positives in the pelvis, you could have a ovarian cyst in the ladies, or even a big fibroid can be mistaken for free fluid. So have a look out for those, check their history if they're conscious. You can check their history and just make sure we haven't got ovarian cysts or fibroids. In the men, if you've got your gain settings wrong, you can mistake like the prostate itself for free fluid. And you can see here we have the seminal vesicles. I reckon this looks like an elephant's head with the trunk. The trunk part here is the seminal vesicles, and you can see it over here as well. And so sometimes that can look like a sliver of free fluid, but as you scan through, you'll appreciate that they're just slightly off from the midline, and they are continuous there with the prostate in the imaging. Now, here's an example where we have the gain set too high. And so if you find yourself squinting at the screen because there's some real bright stuff happening, you know that your gain is set too high, and you need to wind it down, because otherwise that will write echoes in that don't exist, and you could miss fluid in this area. Now, the last part of the abdominal bit, if you like, is doing the subcostal view of the heart. So this is where we are popping the probe right up high in the xiphisternum and angling up to find the heart. Remember, your heart kind of sits mostly in the midline, slightly left of midline, but if you just point the probe straight to your chin, most of the time you'll get the subcostal view of the heart quite nicely. In this image here, we've got liver in the foreground, right ventricle, left atrium. We're looking for the free fluid collecting, particularly between the liver and the right ventricle. That's the most gravity dependent portion. And it kind of is counterintuitive here because you're looking from underneath. The gravity dependent portion is actually further away from the probe. And so when we're looking from underneath, it's not further away, I should say, I'm confusing myself here. When we look from underneath, as we come up here, we've got liver, and then the gravity dependent portion is here. So that's where the fluid collects. Then we get the right ventricle and the left ventricle. But that image is flipped up the other way. So we have liver on top, and then the fluid would collect in here between the liver and the right ventricle. And it's counterintuitive because you're now starting to think fluid should be at the bottom of the screen because that's the bottom, right? That's where fluid will collect. But in this view, because we're coming from underneath, it is a little confusing. It actually sits between the liver and the right ventricle. You may need to move your probe a little to the side. Now, what we're going to do is pop our probe on the xiphisternum. You're going to drop off xiphisternum quite high in the xiphisternum, push down and scoop, and then just flatten out your probe with your hand over the top so that your thumb's not getting in the way. So we're going to slide down, push, and then start to flatten out the probe to get our view. And as you flatten the probe, watch the screen, because depending on your patient, how much angle you need to be able to see through to the heart. Remember, this one we need to increase our depth to 26 centimetres to be able to see all the anatomy that we need. You can see here we drop off xiphisternum, bit of pressure, then scoop. And the corresponding image, you can see the heart beating there. Right ventricle, liver at the front, right ventricle, left atrium, right atrium. So the fluid will collect in between the liver and the right ventricle. You can see on this one, fluid collecting. We can also, this is quite a big effusion, so you can see a little bit of fluid collecting deep as well. When the right ventricular wall collapses, that's when we start to think of tamponade. On this occasion here, you can see that there's some septations in this free fluid. That indicates to me that this is a long-standing effusion. The septations are usually associated with other infection or malignancy. So this is not a traumatic effusion. This is an effusion here with the septations. And if the pericardium stretches slowly over time, it can get bigger and can compensate. Whereas in a traumatic situation, if that fluid in that pericardial sac is collecting really quickly, you'll tip over into a tamponade situation much more quickly. Here we can see a tamponade situation. We've got the free fluid, and you can see this free wall of the right ventricle just collapsing in on itself. That's when we are looking at a tamponade situation. Now, the false positives, there's pericardial fat pads around the heart, and they typically are just here. And so we've had a few in our prac sessions here where they're healthy patient volunteers, and we're like, have they got free fluid? And it's not, it's pericardial fat pad. So if you wind the gain up a little bit, you'll be able to see that there's a bit of stranding, whereas free fluid, there shouldn't be any stranding in there. Now, the last part and the E part of the eFAST exam is to look at the lungs to see if there's any pneumothorax. So we're popping our probe on the edge of the ribs here. The pleural, we look for the rib shadow, and you can see the ribs here. I look for the round rib shadow because deep to that is where my pleural line is sitting, and we have another rib here. So my eyes tune into the ribs first so that I identify the right line as the pleural line. If you have quite muscular men, sometimes the intermuscular fascial layers can be quite bright and echogenic. They shouldn't be moving, whereas the lung line should be moving. As the patient is breathing, the parietal and visceral pleura are sliding over each other. And so you see this sort of view here, those ants on the wire or that shimmering pleural line, and that tells me that there's no pneumothorax. In a patient with pneumothorax, what happens, the lung collapses, and so the sound is still interacting with air, but there's no lung sliding. And so what we see is an absent sliding of the lung here. Now you can see the respiratory effort in the muscles on this patient, but there's no shimmering of that pleural line. Again, we've got the rib. This one is the pleural line. And if you compare it over here where it's shimmering and sparkling at you versus no shimmering here, and that's what tells me there's a pneumothorax. The reverberation of the air in the inflated lung is the same as the air in the trapped air in the pleural cavity in the case of pneumothorax. The difference is the lung sliding. And when you have the pneumothorax, the lung is collapsed, and so it doesn't slide. And you don't see those two layers sliding over the top of each other. So what we need to do when our patient's in the supine position, the theory is here is that the air from the pneumothorax will rise. And so we need to find the highest point along the anterior chest wall to scan to find the air in the pneumothorax. So we're going to pop our probe in the longitudinal orientation so that we can identify the cross-section of the ribs, which makes identification of the pleural line much easier. Then come down a rib space and do the same thing on the other side. Now, the reason we put the probe in the longitudinal position is so that the rib is round and not mistaken for the pleural line. If we put it in the transverse, you can see the pleural line is reflective with reverberation and grey behind it. And if we were on top of the rib is highly reflective with shadowing behind it. And when you're in a hurry, you don't want to mix up those two things. So we put the probe on in the longitudinal orientation because the ribs are round and very easy to identify. And two, because when we're breathing, as much as the lungs fill in all directions, the most movement happens in the up and down plane. So the diaphragm moves down and there's more movement longitudinally than there is in other directions. And so it makes it easier to appreciate that lung sliding. Now you can use either the curved or the linear probe. As I said, if I'm using the curved probe here, I want to bring my depth up to 6 centimeters so that my focal zone is at the pleural line. If you're not sure about lung sliding with the curved probe, that's when I'd change over and use the linear probe. And you can see the difference here. The curved probe, you can see the lung sliding. Made it. And the linear probe. And it's much more obvious here in the linear. And so what we're looking at, we see the cross-section of the rib here, and then that pleural line, and we're looking for those layers to slide over each other. At the top here, we've got the subcutaneous tissue. We've got the intramuscular layers here, the intercostal muscles. We can see the ribs, and that's why you focus and find the rib first, and you see the pleural line deep to the ribs. You can see lung sliding here, and then no lung sliding. Here's our rib, here's the lung line, and there's no sliding. I can see the muscles sliding over each other. So this patient's trying very hard to get some air into their lungs, but the lung is not shimmering just here. So it's a big topic to cover. I probably have gone over, and I apologise for the technical issues we're having here, but those 6 views that we're going to do, the right and the left upper quadrant, we're looking in those 5 places: above the diaphragm, between the diaphragm and the spleen or the liver, between the spleen and the liver and the kidneys, and then at the bottom of the kidneys and around the top of the solid organ. When we look in the longitudinal position in the pelvis, you're going to drag the probe down, bump the bone, point it straight to the floor, use the corner of the bladder as your guide. It points to where the fluid is quite deep. The heart view, we're going to go drop off the xiphisternum, apply a bit of pressure, and then scoop the probe and flatten it down until we see the heart beating, looking for fluid between the liver and between the right ventricle. And we finish it by looking for signs of pneumothorax. The probe is in the longitudinal orientation on the highest point of the chest wall, and we do a couple of different rib spaces here, looking for lung sliding. So I hope that's been helpful for you. If anyone wants to get in contact with me, here's my details to get in contact. And I'll also draw your attention to Zidu's Coaching Corner. I've done the first Thursday of the month at 7:30. We do a free webinar. All you need to do is go to our website at ultrasoundtraining.com.au to register for the website, and then you'll get emails a week out saying, here's what topic's coming up. The link is sent. We get a 2-hour reminder, and you can join us live, or you can go to the Coaching Corner page, and I have a lot of topics there. So if you're wanting some how-to videos on any topic, really, head to our Coaching Corner page, and I'm happy to take some of your questions, although it's probably going to be via the chat box here. So I hope that's been helpful.
Thank you so much for your lecture. I think she's not hearing it. Well, you know we're facing some technical issues. Nevertheless, you will have the chance to ask questions. They will be texted to her. Are there any questions? Yes.
Yeah. Okay. Hello. I would like to ask a question. Is there any situation where you wouldn't do eFAST or FAST in like emergency situation, like considering some critical bleeding or something like that? Or is there any other situation where you wouldn't do the eFAST? Thank you.
Okay, we're just going to wait for the typing.
I've got a question here. Is there any situation where you wouldn't do an eFAST in an emergency situation?
Yes.
It's interesting, you know, I watch those medical shows. We've got a show over here on TV, and it's filmed at the Royal Melbourne Hospital in the emergency department. And I think anyone that goes into the resus bay gets an eFAST exam. And sometimes the history is, I'm sitting there going, what are they doing that for? But I think as much as anything, they're just practicing their skills so that when they really need it, they've got those skills. But I think it's based on history. The eFAST traditionally is that focused abdominal sonography in trauma, and the E part is adding the lungs to look for signs of trauma in the chest. I myself have had an eFAST examination for an ectopic pregnancy, looking for trauma. So it can be as part of a rush exam if you have a shocked patient and you don't know what's causing the shock. You can go through a sequence of images to quickly get to the point where you think, is it like is it the pumps are full? Is the tank's empty? Is it something wise? Is it something leaky tank and there's some problem where you're losing blood, or is it shock because they've got septicemia or something like that? So you go through that sequence of images in that undifferentiated shock patient, and it can help you get to the answer. But having said that, I did a case one time at a local hospital, and the patient had been jumping off a pier or something, had bumped his head and ended up being pulled from the water, having nearly drowned. And there wasn't any, he got a fast scan, there wasn't any classic signs of trauma per se. We did the fast scan and we saw so much fluid, but it was contained within the bowel loops, which is really confusing, but not free fluid. And that could be a mistake that's making. But I was really curious, why are we doing it on this patient who doesn't have signs of any sort of trauma to the abdomen? But again, I think it's as much about getting everyone practice as well. Hope that answered your question. How do you see the future of ultrasound involving and impacting healthcare? I have been on a journey with point-of-care ultrasound coming up on 16 years now. And when I started as a sonographer, you know, I copped a lot of flack from my colleagues, but it was just every now and then there was a couple of doctors at the very tertiary centres that did point-of-care ultrasound. And what I've seen over the time is how point-of-care ultrasound can bring together and break down those silos of medicine. Point-of-care ultrasound can be used in anaesthetics, in emergency, gastroenterology. There's lots of different places. It's kind of a common language across all the specialties. And I think that it only has the potential for more people to get skilled in it and for it to impact patient care a lot, rather than I don't believe in Austria that you have the profession of sonographers, but certainly over here, not everyone gets to go to see and get a medical imaging department scan. And so the point of care has an enormous impact because it allows you to answer questions now and guide management now. And I think that will continue on into the future. I have a question. How do you recommend to stay updated and proficient in ultrasound technology and technique? You have to practice. You have to practice a lot. This is not a skill that you learn in a day or two. I use the analogy of when you learn how to drive. If you remember when you first were learning how to drive and you were driving a manual car, you can't get started without bunny hopping, and you don't go and drive on the open highway straight up because it's too fast and too much and it's scary and you could get killed. So you do little bits around the neighborhood and you practice often, and it's lots and lots of little practice sessions that build the skills. Now it's the same thing in ultrasound. Lots and lots of little practice sessions will build the skills. There's heaps of free online open access medical education resources, and I've pointed out our coaching corner just as a starting point. We've also got a number of other catalogued medical resources there, including any sort of phantom you want to make that's been published in the last 30 years. We've got the instructions there, except for the lady who did the really lovely vascular access phantoms from Sono4You Graz last time. So I have to get her paper actually. But there's lots of free resources on our website to what we've looked through and seen as good quality education resources. The coaching corner, there's a big library of webinars. So you can read up a lot, but the really important thing is that you have to practice. And I'm always telling people after a course here, try to do 2 patients a day and scan for 5 minutes on 2 patients a day. Even if it's just getting the machine out, getting in the habit of getting the machine and getting confident with actually putting it on the patient and using it. It's only through lots and lots of multiple micro practice sessions that you'll develop the skills. So it's really important that you find whatever opportunity you can to get some hands-on practice to develop your skills. Any other questions there?
Do you have another question?
No worries. I hope that's been helpful for you all.
Okay, thank you, Suean. I don't know if you're hearing us still. Yeah, that was a very inspiring lecture, and it's really a recommendation. Check out Zido Ultrasound Solutions website. And they also have a YouTube channel, so you can check that out too. Suean actually is from Australia, as you might have noticed by her accent. She is one of the most thought of speakers worldwide regarding ultrasound, and one of the leading ultrasound, the leaders of ultrasound education. She founded her company, Sido Ultrasound Solutions, in 2007. And yeah, it's they offer courses not only for doctors, but also for nurses and midwives and other health practitioners. You will find several videos on YouTube for midwives, for example. Yeah, she joined us in 2018 already for the keynote lecture, and it was an honor to have her here again. Thank you.